So I think we're going to start. But thank you very much, everyone, for coming to our innovative discovery series. We are absolutely delighted to have Neil Goldstein again coming back today to give us a talk about correlates of infection in the NICU. But before I introduce him, let me mention some housekeeping issues. For CMA credit, you must sign in and must include your email and credentials. Next week we have a tech talk, April 6th, with UD's Michaela Taufer speaking on leveraging big data analytics to examine food nutrient content. And then we have another IB series on April 21st with differences in patients and physician perceptions of care for patients with myeloproliferative neoplasms, which will be presented by James Mangan from Penn. And as usual, our full schedule is posted on our website, DE-CTR.org. So Neil has come back, and we're really happy. He gave us a talk, I think, a year or a year and a half ago. Very, very interesting. Neil is currently a research assistant professor in the Department of Epidemiology and Biostatistics at Drexel. And he's also a postdoctoral fellow in the Department of Pediatrics here at Care. He has a Master of Biomedical Informatics from Oregon Health Science University and a PhD in Epidemiology from Drexel University School of Public Health. He is a very prolific writer, has many peer-reviewed publications, but also has written a book which has just been published, right? And it is Improving Population Health Using Electronic Health Records, Methods for Data Management and Epidemiology Analysis. I'm going to get a signature for him. I want it. That sounds really great. And in 2009, he also wrote a book chapter about transforming healthcare through information case studies. He has a very deep involvement in public health issues, as evidenced by some of his publications, such as Privacy, Security, and the Epidemiologist in the Era of Electronic Health Record Research, or Who Votes for Public Health? An analysis of 25 years of US Senate voting on public health legislation. I think you should come back to give us this. I would love it. Or he also has more technical publications such as Bayesian correction of misclassification of pertussis in vaccine effectiveness studies, how much does underreporting matter, and he's also an active blogger on epidemiologic statistical methods of public health issues. So thank you again, and we are very excited about your talk.
Hello everyone, this is I was telling Claudine that if you ever want to pad your CV, collaborate with someone in academia, because they publish so extensively there. It's very easy to become co-author on numerous publications. So thank you for the intro. Again, I'm Neil Goldstein. I am talking to you today about work that I've done the last 2 years here at Christiana in my postdoc. So a subtitle of this talk could just really be what's been going on in my life at Christiana. I'm happy to say that I actually have a funding disclosure. I was recently funded for a study from Merck, but that's nothing to do with the topics I'm going to talk about today. So when I started here in the postdoc, I started in pediatrics. I had previously worked in infectious disease, but never specifically in neonatology. The next 2 slides then are my attempt to tell you everything I know about neonatology. And so, for example, what I recently learned is that babies come from moms, not from stores. But it's the characteristics of the moms that I want to start with here. So we're talking about what leads babies to become colonized and possibly infected with various pathogens. So it could have something to do with the mom during pregnancy. Did she have some sign of inflammation like chorioamnionitis? Did she have an infection? Like how did the pregnancy go? That's kind of the first step. So what's going on in utero with the baby? And then you get to the baby themselves. Maybe they were born premature, so the immune system was underdeveloped. These are kind of what I would call intrinsic factors that are markers of possible colonization, possible infection in the neonate, but something to do with the characteristics of the baby or the characteristics of the mother. Where I want to go with the talk today and with my work is what are the extrinsic factors that lead babies to become possibly colonized and infected with various organisms. So there's, if we acknowledge that vertical transmission is possible, like stuff that happens from the mom to the baby, this could be in utero, this could be during childbirth. There's all sorts of opportunity for horizontal transmission of organisms. These could be related to the patient care team. These could be related to the characteristics of the neonatal ICU, or it could be something like fomites. It could be medical devices that serve as reservoirs for different organisms. And to frame the talk today, I'm going to introduce the epidemiologic triad, and this is something that, if you've taken an epi course, you've probably seen this before. It's a way to talk about transmission, horizontal transmission really of organisms, and how they relate to three core factors, the host being the person, the agent being, in this case, the pathogen, and the environment being where all these things interact. So let me give you an example of how this is used, and from maybe more like a public health perspective, and then we can talk about how this works for the studies that I'm doing here at the hospital. Take cholera infection. So cholera is a bacteria, causes GI illness, and the agent in this case would be the bacteria itself, the cholera bacteria. The host would be the person, and the environment would be where they live. So the idea is that you can block transmission of disease by kind of canceling out one of these pathways. For example, we can block the cholera to person pathway by making the person immune to cholera, so giving the person cholera vaccination. You can block, say, the agent environment pathway by making the environment less habitable to cholera. For example, cholera is often passed through contaminated water, so we can chlorinate the water to make it less likely that the cholera bacteria can thrive there. And we can also modify the host environment pathway, say making sure that people have access to clean, potable water and are not drawing water from contaminated sources. So now we can use that framework to talk about the work that I'm doing here in the neonatal ICU. So again, we have the host now. It becomes a baby. We have various pathogens. For a lot of the talk, I'm going to focus on methicillin-resistant Staph aureus. It's not terribly common, but it's a good one to talk about because the consequences of colonization with MRSA are dire, and that about a third or so of babies that become colonized with it will go on to develop invasive infection. So it's a good one to kind of fit this framework to. The pathway between the pathogen and the neonate, that's more of like these intrinsic factors that I'm talking about. And where this talk goes is to say, what are the characteristics of the environment? So what's the characteristics of the NICU that make the pathogen thrive there, as well as what's the kind of the link between the baby and the NICU? So we're going to answer three broad research questions here. The first, and this was the talk that Claudine mentioned earlier, about a year ago, so I'm only going to touch on this briefly, is does occupancy, and I'll discuss what that means in a couple of slides, does occupancy lead to a greater risk of late-onset sepsis? Second question is, how does the patient care network, and I'll get into what that means in a little bit, of the NICU influence transmission of MRSA? And finally, what are the spatial and environmental correlates of colonization and infection? So let's start with that first research question. And now that I've put the epidemiologic triad back up there, you can see how I've highlighted, I don't know if you can see that, it's in red. I've highlighted parts of the pathway that I think are the ones relevant to the research question of interest here. And I'm also introducing now a new thing into the triad that I didn't talk about previously. That's the notion of a vector. So to go back to my previous example, like more of a public health example, a vector could be something like a mosquito. If we're talking about transmission of malaria, the vector would be a mosquito that's interacting between all of these three factors. So in this case here, my vector has become people that are in the NICU. This could be the healthcare worker, or it could be visitors. For the studies that I'm talking about today, I'm going to give just kind of a brief overview of the research design, like how we're recruiting the patients into this study. And this kind of applies to everything I'm going to talk about. So I'll introduce it at this time. It's a retrospective cohort that's drawn from electronic medical records. And what we do is we've looked through, about 1997 to 2014, almost 2 decades really worth of data here. About 20,000 admissions to the NICU during this time. And we can follow the babies during their course of stay in the NICU, and we can follow them until the time of one of these outcomes occurred, whether that's, in this case, late-onset sepsis, or in another case, colonization with MRSA. And we can follow them until they are discharged, transferred, or if they die in the unit. So there's these, we can look at this and calculate incidence rates on the basis of what's going on with the babies while they're here in the NICU. For this particular study here, the exposure is this notion of occupancy. So my outcome is late-onset sepsis, that's lab confirmed, culture-proven. And I want to know, how does occupancy influence the risk for infection? But there's the notion of occupancy is kind of nebulous. So in one sense, it could be just talking about the number of occupied beds in the unit, what most people call census, or it could be some characteristic related to the properties of the babies that are occupying those beds. So maybe it's just the proportion of very preterm infants in the unit. This would be some overall measure of acuity of the unit. Or it could just be operationalized as what's the doctor or nurse to patient ratio. And so what we saw when we did this cohort is this is just a quick table that shows you breakdown of late-onset sepsis and lab-confirmed late-onset sepsis by the years in our study. And you can see that there's that definite nice trend of late-onset sepsis declining over time. You can see kind of the proportion contributions from the various organisms there. I'm not going to focus really too much on this because, again, I did talk about this previously. What we saw, though, and when we looked outside of just the intrinsic factors of the baby, we started to look at, say, what are some environmental characteristics or characteristics of the unit. We saw that their occupancy really did seem to influence, to some respect, the outcomes. And the estimates here, they're rather modest, right? We're talking 2% increase based on the proportion of return babies in the unit. But this is also for like each percentage increase in babies in the unit. So take a unit that's got like a 10% acuity versus a unit that has a 30% acuity. That's a 20% difference. So all of a sudden that becomes a 40% increase in the association with sepsis. For this particular study, the limitations really are, it's not the exposure in and of itself that's causing the outcome, right? It's not just like by virtue of there being more sick kids in the unit that somehow this relates to this is causing late-onset sepsis. So it's this notion of a proxy exposure. And that's kind of where we're going with this work, is we wanted to get in what are these characteristics of the unit that are leading more babies to become infected. So just some brief conclusions from this study, and what we saw is that it appeared to be the acuity rather than the census, the pure just bed count that was driving the association here. And as well as if you're doing, just for future work, if you're doing studies looking at healthcare-acquired infections, it's worthwhile to include some marker for occupancy. That brings us to our second research question here. How does the patient care network of a NICU influence transmission of MRSA? By way of a little bit of background here, this is focusing on horizontal transmission, and in fact, this is all MRSA colonization. I'm not looking at MRSA infection here. So MRSA colonization can be passed around from peer to peer. There's been some previous evidence to suggest that 20 to 40% of patients' flora in an ICU are the result of cross-contamination from the healthcare worker. And one of the strongest correlates of that is lack of proper hand hygiene. As I'm defining hand hygiene here, though, it's comprised of two factors. And these are two distinct factors. One is compliance. So compliance is just, are people doing this, right? It's putting someone there to observe patterns, say, all right, these people are compliant with the hand hygiene. But the other component to that, and this is a little bit tougher to assess, is efficacy. And that is to say, like, if you do hand hygiene, are you doing it correctly, and does it remove whatever the organism is that's colonized on your hands. If you've gone to one of the infection prevention talks or have seen like Dr. Tuttle do her thing, it's really fascinating because you watch her use like the alcohol gels, and she's rubbing and rubbing, gets the thumbs, gets the tips of the fingers. And so that's the notion that you could be perfectly compliant, but it could not be 100% efficacious. Those two things taken together then lower the effectiveness of hand hygiene. All right, so what we want to know then is how does hand hygiene in some way, with hand hygiene as the intervention, how does the patient care network influence spread of MRSA colonization within the unit? Well, what we need to do, and this is really the focus of this particular study here, is to assess what I was calling the patient care network. And that is to say, as the healthcare workers interact with the babies in the unit, they'll go and they'll do something, they'll take care of one baby here, and then they'll go over and take care of another baby. And as you start branching out, and you can link more and more babies together by healthcare workers in common with those babies. Each and every time that they go from one kid to another kid, there's that opportunity for hand hygiene. So you can build this patient care network by looking at the electronic health records and seeing the interactions that they've had with kids. But it's not that, we're not looking like every single interaction that could possibly occur, because for one, they're not all documented in PowerChart. If it's just some very minor interaction, it's not going to be documented in PowerChart. So what we want to focus on here are the contacts that a provider had with a baby that has the potential to transmit the pathogen. And we're able to do this using something called the Fulkerson scale, which defines essentially it's a ranking system to say, based on this kind of interaction, we hypothesize that it has this risk to spread organisms around. So using the Fulkerson scale, we can rank all the different interactions providers have had with the babies in the unit, and just draw out the ones that we think have the potential to spread MRSA. Here's just a top 5 list of the interactions that we observed in the unit here. So about a third of the time that a provider is interacting with a baby, it's to assess vital signs. And it doesn't even have to be like interacting with the baby, it could just also be interacting with the environment around the baby. So doing that, you end up with something that looks like this mess. It is a typical day in the NICU. And this is real. This is based on our NICU here. This isn't just like some hypothesized thing that I made up. I looked at a particular day in the NICU, and there happened to be 52 babies in the day at that time. So each of the red dots on this graph depicts one of those babies. And then the black lines going between the red dots represent the connections between babies as a result of healthcare workers in common. So they saw one baby, they went on to see another, and so on, and collapsed over the day. You end up with this bird's nest. So when I looked at this, I mean, when I see this, it's remarkable how many hand hygiene opportunities there really are, that each and every one of these has its own function of, did you do it correctly, that kind of thing. And I want to now show you a video of how this dynamically operates. So let's see if this works. Okay, what you are looking at here, the dots, again, represent babies in the unit. Now we're looking at more or less a 9-day period in the unit. The median length of stay for the time I was looking at was about 9 days. So over those 9 days, we assess 1-hour care bundles. Each care bundle is what the healthcare providers did with that baby, and then I'm connecting them to other babies in that hour. Each of those lines represents a possible connection. So as I step through hour by hour in the NICU, you see how this network really evolves over time. There's 2 colors depicting the nodes here. There are blue nodes and there are red nodes. The nodes are just the little circles, so again, those are the babies. The red nodes indicate babies that are colonized with MRSA right now. The blue nodes indicate babies that are essentially susceptible to MRSA colonization. As the providers interact with the babies and as they go on to interact with other babies, there is the potential to spread MRSA.
Hello?
And so that's why you would see at the start of this video, there are only 2 red nodes. And if we step through this thing the entire 9-day period, we're going to end up with 5 red nodes at the end. So that suggests, based on the current level of hand hygiene that is employed in this model, we've gone from 2 initially colonized babies to 5 colonized babies after the simulation. Now, what we can do with this, because we've built this care network now based on empiric data in our unit, we can start asking different what-if questions to this. And that's the basis of the sensitivity analyses that you'll perform here. So one thing we want to do is just vary the prevalence of MRSA in the unit. Let's start with the case of just if there's only 1 colonized baby in the unit. And based on the result of infection surveillance, I know the maximum number of colonized babies in the unit for this period of time. That happened to have been 4, so I'll start with 4 colonized babies. We'll also want to vary the level of hand hygiene. So we can, for a baseline comparison, we can just say, let's suppose there's no hand hygiene going on at all. How does just that patient care network result in the spread of MRSA without any hand hygiene? And then we can bump it up to the other extreme, and we can say, suppose there's 100% effectiveness. So that's 100% compliance, and everyone's doing it right. We have these extremes. We acknowledge that they're unrealistic extremes, that the real value is somewhere in between. And we can play with those values to see how it influences the spread. Finally, we also want to consider some intrinsic factors. I know that the focus of this talk are these extrinsic factors. But we want to talk about some intrinsic factors because we know that if the baby was born premature, if they are on mechanical ventilation, that there's going to be more provider interactions with that baby versus an otherwise older, more stable baby in the unit. And one other factor that we consider here, although it's really the focus of the final research question, is the location in the unit. So as I'm using that here, if you're familiar with the NICU, it's kind of a U-shaped design. There's 3 halls, and there's a couple of isolation rooms in the middle. What I do is just put babies into each of the 3 halls to see if that somehow influences the risk of MRSA colonization. Here's one of the first findings that we had. So to describe this graph a little bit, the y-axis is the prevalence of MRSA colonization post-simulation. So that means after I've run this simulation for 9 days, or I haven't run it for 9 days, you know what I mean? It's been going on. The NICU lasted for 9 days. So that's the post-simulation prevalence of MRSA colonization. The various, along the bottom there, you have the number of initially colonized babies. So at one extreme we had 1, at the other extreme we had 4.
What's the 1.9, 3.8?
That's the proportion, so that's the prevalence proportion. This is 1 colonized baby, so that's about 2% of the unit. And during this average NICU of 52 babies. And likewise, if you had 4 colonized babies, that's roughly 8% of the unit is MRSA colonized at that time. The bars that are the bars that you see above each of the number of initially colonized babies correspond to the varying levels of hand hygiene effectiveness. Again, at one extreme we had no hand hygiene, that's the white bar. At the other extreme, the black bar is 100%. The true value is somewhere in between. So when I first saw this graph, I actually thought that there would be this plateauing effect, that at some point there would be less return for more hygiene effectiveness. And I don't really see that here. I mean, maybe to some gradual extent, but in the case of a larger number of MRSA colonized babies, you don't have that plateauing, which to me suggests that there really is no level of hand hygiene compliance that's good enough. You can't just stop and say, oh, we've got 88% compliance, that's really good. It can still break through despite high compliance. This quantifies what I'm talking about a little bit more, so I want to just focus on 3 lines here in this table. Suppose we start our simulation with 2 colonized babies in the unit, or roughly 4% prevalence. No hand hygiene at all. After 9 days, you end up with about 10 MRSA colonized babies, or roughly 20% of the unit is now colonized. Using that as a reference, suppose we had 48% effectiveness. This 48% number is actually derived from the literature, and it's kind of the mean reported hand hygiene compliance that's been seen in other NICUs. Actually, the compliance is probably about 55% from this literature review, but what I'm also doing is I'm incorporating the results of an RCT that suggested the efficacy of using some kind of hand hygiene is about 88% efficacious at removing MRSA from the healthcare workers' hands. So taking the product of those two yields this hand hygiene of 48%. Interpreting this line for you, that means that starting with 2 initially colonized babies at 48% hand hygiene effectiveness, after 9 days we have about 5 colonized babies, or roughly 10%. Nevertheless, it's still about a 50% reduction over no hand hygiene. The bottom one here, 88%, this is what I think is the theoretical maximum. So if you have 100% compliance combined with about an 88% efficacy for removing MRSA, then you begin to really control the number of, we don't see this increase in the number of MRSA colonized babies after the simulation. We started with 2, we ended with 2. Even declined ever so slightly, 81% reduction in colonization. Here are some of those other factors that we modeled in this study. So we looked at just being preterm, and I'm just defining that here based on the standard less than 37 weeks gestation, whether or not they had their trachea intubated, as well as the location within the unit. And as expected, because there are more interactions with these babies, we see that compared to not being preterm, that being preterm, there is roughly 61% increase in prevalence of MRSA colonization. Being intubated had roughly a 27% increase in MRSA colonization. And interestingly, there was this kind of location-specific effect. And so how I would actually explain that is the majority of care that happens in the NICU, the majority of care is delivered by the bedside nurse. And they are just within very specific areas. They're only taking care of 1 or 2 pods within the unit. And they are, so there's some kind of like natural isolation effect happening just based on the halls themselves. The physicians, some of the technicians, they'll cross the hallways, but from what the data suggests here is it's really, there's this like isolation effect happening. So if I start putting more MRSA colonized babies in one particular hall in the unit, they tend to stay in that hall. All right, so some notable limitations to this work here. Everything just takes into account right now the healthcare worker as this vector, as the intermediary passing around the pathogen. I'm not accounting for visitors. I don't have good visitor information. Also not really taking into account fomites, so people walking around with their cell phones or whatever other inanimate object could harbor some organisms. And then, and I spoke about this to some extent already, these models are limited in the ability to tease out specific effects. I'm taking this product approach to doing the work. For example, the way the model is constructed is I look at infant-to-infant connections through the healthcare worker. But I can't break down the individual, like, is it from the infant to the healthcare worker that's the problem? Is it from the healthcare worker back to the infant that's the problem? As well as I can't talk about what the difference between efficacy and compliance in terms of health, in terms of hand hygiene is. On the other hand, a nice strength of this work is this is all, again, based on real data in our NICU. This is data that I mined from PowerChart. This is a real, it's all based on actual encounters that happened between the healthcare workers and the babies. So conclusions to this work, no good enough level of hand hygiene, even in the face of perfect compliance, just because the efficacy will never be as perfect. There's still the opportunity for MRSA transmission. The greatest risk seemed to be, this to some extent may be obvious, the greatest risk for MRSA colonization was those that had the most contacts, but we were able to actually quantify what that was. And finally, it suggests, as the unit currently employs, in the time of high number of MRSA colonized infants, other interventions are warranted. All right, and that brings us to the final research question. What are the spatial and environmental correlates of colonization and infection? As by way of recapping where this talk has gone so far, we've determined that determinants of infection, independent of the characteristics of non-characteristics of the kid, appear to be influenced by acuity of the unit as well as the amount of care required. So now we want to kind of interrogate the unit a little bit more and say, what is it about the NICU that leads to potential for colonization and potential for infection? Let me take a step back first and ask the audience, have you guys heard of Jon Snow? Not the Game of Thrones Jon Snow, but the epidemiologist. So he's considered one of the founders of epidemiology. And so his work would be known as what we call spatial epidemiology today. Mid-1800s, put yourself in London, cholera is running rampant. What he did is, this, to some extent, it may seem simple today, but at the time it was groundbreaking, especially because it really wasn't understood what the organism was that was causing the disease. So he takes this map of London, starts coloring in the homes where cholera cases occurred, and lo and behold, observes that there's certain areas in London where there's more cases of cholera, and in fact traces it to a contaminated well. The well gets locked, people can't draw their water from that well anymore, and the cholera epidemic begins to subside. As we say then in public health, place matters. Just place matter in the NICU, and that's where we're going with this. So there's a few different things that I wanted to look at here, and these are potential reservoirs for pathogens. Let's see, I want to do this. Yeah. Okay. So there's properties of like where you are in the unit. For example, some of the pods in the NICU, there only is room for a single crib in that pod, whereas other pods is more of a shared area. You can put up to 3 babies in that unit. So the question is, does the number of babies in the pod somehow influence risk? At one point, there's some historic questions we can ask. At one point in time, there was a water leak in the water, happened to have Pseudomonas, which led to infection in a few of the babies. There was also at one point in time carpet in one of the halls. And so this has, I mean, not only is that a reservoir for organisms, but any time that's vacuumed and clean, it kicks everything up into the air. So we wanted to know were babies that were in the room with the carpet at that time more likely to become colonized or infected. And we also wanted to know, there's some potential areas that have, so there's refrigerators that have medication or nutrition in them. We wanted to know, are those refrigerators fomites? Are they harboring organisms? As well as there's also certain areas in the unit where you can put babies that has more room for equipment to take care of those babies. So we wanted to know maybe there's some relationship between where you are and the amount of equipment in your area compared to babies that are in other areas that don't have as much equipment. We're looking at 4 outcomes with this work here. We are looking at MRSA colonization. We're looking at culture-proven late-onset sepsis, and really that's bacterial or just Candida. And then in a sub-cohort we looked at just babies that were intubated, and we checked. So there's routine surveillance cultures that happened in the endotracheal tubes for these babies. So we were looking at whether or not those endotracheal tubes were colonized with Pseudomonas or CLABSI. One addition, so this is kind of like while we're here, let's also look at this kind of thing. I'm talking about these like spatial and environmental things, but there also may be some what I would call neighboring risk. And what I mean by that is if you have a baby that's in one pod and the baby in the neighboring pod gets sick, does that, with a communicable organism, does that somehow influence the neighboring baby's risk for becoming infected, becoming colonized? So we wanted to ask that question while we were here. And there are some various policy initiatives employed at various times in our cohort, so we had to account for those as well. The focus of research question number 2 is all about how does hand hygiene operate. Well, with this one right here, at one point in time there was universal gloving. There's also been a unit-specific infection policy put in place. So we need to account for those time periods to just make sure that they are not otherwise influencing. First step is you have to build yourself a spatial representation of the unit. So I see Dr. Antunes in the back. Does this look like the NICU to you? Yeah, so you have the U-shaped pattern here, the 3 halls, the front hall, the back hall, what we call the quiet room. There's a couple of isolation rooms in the middle. So this is now represented digitally, so we can start using this information. One of the things you just may want to do with this is what if we started like shading the pods based on the occurrence of some of our outcomes. So this is what's known as a Cohort cleft map. The more intense the color, the darker the shade of red in this case, the more numbers of cases that occurred in that pod. For what you're looking at here, this was among our sub-cohorts, so babies that were intubated. We're looking at Klebsiella colonization in the endotracheal tubes. My question to you is, do you think that there are patterns here? Does this look random? Raise your hand if you think it looks like there's patterns to this, that there are certain hotspots. Okay, and then raise your hand if you think this is just random noise. Okay, so I got a couple takers on the randomness. It seemed most people thought that that this wasn't random, that there were definite hotspots. If we focus on 202 and 204, I don't know if you can see where this mouth messes. They are the darkest, most intense shades, suggesting that relatively they had the most number of Klebsiella colonizations. Is the fact that both of these shaded dark red influenced by the neighbor becoming colonized? For example, if more babies in 202 were becoming colonized with Klebsiella, is that now influencing 204? Is that my 204 is really dark? And to do that, now we define what does a neighbor actually mean. So I mentioned earlier that the majority of care is provided by the bedside nurse in the unit. And this is definitely not meant to implicate any one person or any profession at all, but just to say that if the majority of care happens as a result of the bedside nurse, I can define my neighbors based on the standard nursing, based on who they take care of in the typical day. And that's how I'm able to define these neighbors. So the connection between pods suggests that if you were a healthcare worker in this pod over here, then you may also have a patient over here, you may have a baby over here, you may have a baby over here. So now we're starting to define these neighbors. All right, we have the environment modeled, we have the neighbors, we have that figured out. We can ask 4 questions in this particular aim here. First question was, what was the distribution of infections and colonizations random or not? When we all looked at the map, you're able to get like a qualitative assessment of that. You're like, it kind of feels like there's hotspots here, but we can do a little bit better than that, and we can quantitate what that is, or quantify what that is. Number 2 is, were infections and colonizations explained by the environmental, the location factors? These were the things that we talked about earlier. So if you were in an area with more equipment versus less equipment. Number 3 is, were the infections, colonizations mitigated by policy? These are the policies we spoke about: universal gloving, the infection prevention policy. And finally, my personal favorite is, did a neighbor influence your risk of becoming infected by colonized? So let's go through each of these 4 ones here. As a reminder, these are the outcomes that we're looking at, which is why you'll see 4 different estimates. To answer the first question, though, non-random distribution, that is, are there hotspots or not? We use a test that's based on the area level variance of the models that I'm using here, and these numbers here, you can just interpret them kind of like odds ratios, standard 95% confidence interval. So how I would interpret this is just based on where you are in the unit, you have an increased risk for MRSA, you have an increased risk for culture-proven late-onset sepsis. Based on where you are in the unit does not appear to influence Pseudomonas, does not appear to influence Klebsiella. So the graph that we looked at a few slides ago, where there was just a couple of takers that said this looks like randomness, it turns out to be that this is most likely just random noise, just random variation over time. Second question, second and third question actually, are there environmental or policy correlates of infection here? So now what we're doing is our test becomes a multi-level model where we have all the infants that have been in the unit for some period of time. They become nested within which pod they're in. So it's very easy for me to tell when I look at the health record which pod these babies were in for their stay. And some of them move to some extent, but for the most part, they're stable in those pods, so I can nest them within the pod and say, all right, what are some of these pod level factors and how are they influencing risk for these various outcomes? Well, among everything that we looked at, refrigerators, location, being in a single versus a shared bed space, the gloving, the infection control. The only thing that really bubbled to the top here was just for Pseudomonas endotracheal tube colonization. It appeared that being in a location with more medical equipment increased your odds of having colonization. And you tend to see this with multi-level models in that the individual factors can overwhelm, or they tend to explain a lot more of the variability than group level factors. And so what that really tells us is that your gestational age mattered more, having a central line mattered more. If you were in my sub-cohort of intubated babies, the number of days you were on the vent really influenced a lot more the presence of colonization. Nevertheless, it's still interesting to note that there are certain areas in the unit where you are more likely to become colonized in your endotracheal tube Pseudomonas. And finally, for that last question of does a neighbor influence your risk? This is a test that uses something called spatial autocorrelation. It just defines your risk based on neighbors. And what we see for our 4 outcomes is that only MRSA appeared to be influenced by a neighbor having MRSA. The other outcomes did not appear to be influenced by the presence of a neighbor having these outcomes. Knowing this, that there's spatial autocorrelation present in the data, we then repeat some of our analyses to take that into account. It didn't change any of our conclusions, though, which is why I present that information here. All right, so to this study, what are the limitations and strengths? These are all historic data I'm looking at. So this is just like this is what happened in the past. It's not necessarily indicative of what's going to happen in the future. As well as I can only model what I can measure here. These are just the things that it was easiest for me to obtain data on. There's a refrigerator here, kind of thing. This pod only has room for so much equipment. That's easy to model. And maybe the reason I'm not seeing so much contextual effects here is just because I'm not looking at the right things. So conclusions from this last research question. That the baby-specific factors that we looked at appear to be primary drivers of most of the outcomes as opposed to the environmental factors. The location analysis suggested that historically, more Pseudomonas endotracheal tube colonization happened in areas with more room for medical equipment. And lastly, that MRSA colonization based on this neighboring influence really warrants isolation, placing these babies in isolation rooms in the unit, given this potential for horizontal transmission and the roughly 30% increase risk for invasive infection that happens when you're colonized. All right, so to conclude, you may say, all right, so what? What do you do with this information? How is this useful for infection prevention in the hospital? This is an example that Dr. Stephen Epps just shared with me last meeting, so it would be a great way to conclude the talk. And in the unit, there has been this surge in central line-associated bloodstream infections, ICs. In fact, 4 in 1 month recently. And when I asked Dr. Epps, well, what are things that you're looking at here? He noted not only what's going on with the baby, but also what are the healthcare workers doing to access the lines? Are they using sterile techniques? The lines happen to be accessed more now as a result of an initiative that was implemented a little while back. But there's also, he was just off the top of his head saying, I think there's possibly environmental reservoirs. There may be some sinks in the unit that could be contaminated, so we can use that information and see if that's true, as well as the potential for contaminated equipment. All right, so work of this magnitude is clearly not possible without a wonderful group of collaborators from among the many people that I worked with at Christiana. Here's a few of them, as well as the statistical techniques to do this. I, again, could not do this on my own, so I relied upon knowledgeable people from Drexel and from elsewhere to help in this work. I also want to acknowledge the Society for Epidemiological Research, as they just selected selected this work, a subset of this work for one of them, and so I'm very grateful to them. And with that, let me open it up to if there's any. Dr. Wenthrop.
Well, it was a fantastic talk. I learned a ton of areas of epidemiology I didn't know much about, which is great.
Great. Thank you.
I wonder about your ability to control for confounding in some of the associations you make. For instance, is the high risk of MRSA with the neighboring babies, is that causal horizontal transmission, or is there something going on where that's really an epiphenomenon?
I mean, yeah. So the question for those in the phone was about confounding and if I can adequately control for that. I think the reality is that some of this does happen as a result of like vertical transmission. So say you have the mom come into the unit, she is breastfeeding. There could be that vertical transmission that's happening there, and we can't account for that in the model. So I would not. I mean, if I'm stating this causally, I should take a step back from that and say these are pure associations. Nevertheless, I think there are associations that are worthy of investigating a little bit more. And where I'd like to go with this is like if we design a prospective study, maybe we can do a time motion study where we can really examine all these things happening in real time and do a better job of accounting for those unknowns. Any other questions? Yeah.
Well, thanks, Neil. This was great, and congratulations for your work.
Oh, thank you.
So you talked about policy on gloving and things like that. Did it have any influence on MRSA, for example, or some of the?
So the question for folks on the line is about the policy and the universal gloving. Did I notice any effects? I did not notice any effects, but I don't think that's because they didn't do anything. I suspect it has to do with the length of time that I was looking at, that any effect kind of got washed out. So I think that they had they put these policies in place for a specific reason at that time, and it probably had a very time-specific effect that I just didn't detect. Yes?
I wonder if there's a possibility with that in mind of doing a run chart or of that time period where, I mean, it might have to be grouped, but
yeah. Just
where in the process those things actually got implemented, and to see if there's any relationship between those policies happening or being.
Definitely. So we can do that modeling wise, and that would be an extension to this work where we take into account like the time varying exposure as dependent upon what's going on at that particular time. Maybe employing that approach would detect these effects that you're describing here. Yes, at the back.
Neil, could you go back to the slide where you show the 4 diseases? So why do you think, have you had any discussions as to maybe even clinically why MRSA, there was a presence, but not for the others?
Why there was autocorrelation, why the neighboring influence?
Right.
That's a great question. Are there any neonatologists? So the question was, why do you see an effect for MRSA and not for, say, some of this, like late-onset sepsis? But so we're looking at one particular organism there, and maybe like the propensity. So sepsis is really this composite outcome of all these different organisms that could cause it, and maybe just like the propensity for some of those organisms to be horizontally transmitted is not quite what it is for MRSA. If I had to speculate at something, I may do that. Neonatologists want
in our population, the other thing. So I think you're right, Neil, about what you just said. So MRSA is colonization for the most part that we're talking about here. Sepsis is highly related to in one of Neil's other slides that what's going on with that patient. So indwelling vascular access that puts them at risk for late onset sepsis. It's much more related to that kind of event than colonization.
Yeah, so the sepsis is like
visual factors. That was the term I was looking at.
Yeah. MRSA is just pure colonization. I mean, the colonization is just done from routine surveillance in the nostrils. Yes.
Okay, thank you. That's really interesting study. If you don't mind, go up a few slides for the random location or non-random location. A few more maybe. Yeah, this one.
Yes.
Some of the studies shows significant, some of are not. So
Yes.
MRSA again on one of those charts up there, and sepsis here. So related to the previous question, why does this happen? Is it MRSA being top and then sepsis here again? The random distribution and then the baby neighbor, to me, is very related. Those two factors. So if there's any correlation between those two, and then you said this is about 20 years of data. In those 20 years, is the equipment location has been changed? Did your study account for those possible change over the years, or you only look at the current layout and then go back to that 20 years data?
So the reason that, so let me start with that question. For the folks on the phone, it was, we have about 20 years of data, and the layout of the NICU may have changed over that time, and the equipment may have changed location, that kind of thing. The reason we start with 97 is because that's when the NICU was built in its current design, this open pod. So the layout itself is not changing, but the presence of like refrigerators or other equipment or the carpet in the room, what we've done for those is we only introduce those exposures at that point in time. So to the extent we're able to account for knowledge of something changing over time, like the carpet in that quiet room is a great example. The carpet was only present for the very first few years of this very long cohort. So we only look at that carpet for those 2 specific years there. The former question that you have about why do we see these, so I'm looking at these non-random distributions, and we only saw that MRSA and sepsis had some like location-specific effects. Why don't we see those for our sub-cohort? Great question. I'm not sure the reason to that. There's the sub-cohort is fewer numbers, so it could be a power issue. It could not be. It could also just be that these are false positives. Maybe there is no true location effect. The MRSA one is interesting because like the 60% increase based on where you are in the units. I don't know. Maybe I'll buy that. There's a lot going on, like unpacking the late-onset sepsis one. The MRSA colonization one's a little bit interesting. I actually think part of this just may be an artifact of the isolation rooms, and that MRSA colonized babies are likely to be placed in those isolation rooms. And so maybe what you're seeing is just that the 2 isolation rooms are next to each other, and that's what's really driving this number as opposed to being somewhere else in the unit. But with the MRSA, one of the things I didn't talk about with the MRSA, with this, the way that the surveillance occurs for MRSA, we're not capturing everyone there. So there is some possibility for other things going on, and maybe this is just a result of some kind of information bias. Let me get some fresh blood, and then I'll come back. In the back, Dr. Hansons.
You know, the sepsis thing, one thing to think about in your model,
Yes.
may be individual factors as well. Because in your model, do you assume that admission to all of those 23 bed spaces is random? Because it's not.
To the extent that it's my understanding is that it's based on availability, and not necessarily based on acuity.
But it is based upon acuity.
Okay, that's an issue.
You have to, there's physical restraints, size. And so for the tiniest of babies who are going to need 3 ventilators for, they have to be in the big bed spaces. And so admission to bed space is not really fully random.
And so for the folks on the phone, the question was about, are the babies are not randomly admitted. Certain babies are not randomly assigned bed spaces in the unit, so maybe that the fact we're seeing some correlations aligning with bed spaces have to do with the intrinsic factors of the kid, how sick they are. These models do take into account some markers of the acuity of them. We take into account their birth weight, their gestation. There's other things that I haven't put on this slide here, but we take into like what were the characteristics of the mom, if the baby is receiving antibiotics, or the central line, the length of time that the line was indwelling for. Like we've taken into account those factors as best we can, and even above and beyond those factors, this for Pseudomonas, this is the only one that like bubbled up to the top. I saw another question towards.
I thought the model was very compelling about the spread of the number of colonized
The video?
babies. Yes.
Yeah, that's the video is the eye candy.
Yeah. Well, that eye candy, given that hand washing can never be good enough, I think has huge value as a informational dissemination tool as a motivational strategy for healthcare workers. I don't know what the rest of you say.
Yeah, they actually just sent out to all ancillary departments reminder of bare to the elbows and scrubbing and all that sort of stuff. So something like this to go along with that, I represent chaplaincy, is pretty impactful.
Yeah. I mean, all for disseminating this. It takes a lot of explanation, though, to know what's going on here. So this loop actually runs for, I think, like 2 minutes or so, and it takes me about the full 2 minutes to explain that. So I don't know how you so much get that into the words. I don't think you'd want me to record something and have my annoying voice playing over top of it while people are watching it. Great, thanks everyone for coming.